Okay, I think we're probably good to go. Hello everyone, and welcome to our 10th Alport online workshop, New Treatments and Clinical Trials. For those of you who don't know me, I am Susie Gear, Chief Executive of Alport UK. Alport syndrome impacts me and many members of my family. This week, I am celebrating getting a new pair of hearing aids that are transforming my life. They're rechargeable, so I no longer need to feed them endless expensive little batteries, and the hearing aids automatically stream phone calls and film sound, etc., all thanks to a great Bluetooth function. In what can be a very challenging Alport world, it is nice to have something to celebrate. On to our workshop. Today we have two presenters who will review how current treatments work in Alport syndrome and the way future treatments may work. We are very privileged to have Professor Oliver Gross as our scientific moderator. Oliver is Professor of Medicine at the Clinic of Nephrology and Rheumatology at the University of Medicine in Göttingen from Germany. As a researcher himself, Oliver knows the importance of clinical trials, having set up the first trial in Alport syndrome, the Early Protect trial, looking at the value of ACE inhibitors for Alport patients. Today, Oliver will help me put the questions to our speakers. Archie Walker and Harriet Carter will run the production of this webinar today, so do message Archie or Harriet using the chat function if you have any issues. Right, now that's over, let's begin with some introductions. We have two amazing women as our speakers today, and as paediatric nephrologists, they combine busy clinics to look after children with kidney conditions, also with exciting research work, and they are mums who have busy home lives. It is a great pleasure to welcome Rheault Lennon, Professor of Nephrology and Consultant Pediatric Nephrologist at the University of Manchester in the UK. And Rheault will talk to us about how do treatments work in Alport syndrome. Secondly, we have Dr. Michelle Rheault, Associate Professor and Director of the Division of Pediatric Nephrology at the University of Minnesota in Minneapolis in the USA. Michelle will tell us about Alport syndrome, current and future therapies. Right, that's enough from me. I think it's about time I hand over to Rheault. Rheault, would you mind sharing your screen and taking us away? Great, we can see your slides. I can't hear Rheault at the moment. Rheault, can't hear you at the moment.
Yeah.
Ah, we've got you. Excellent.
Okay, brilliant. Sorry about that.
Don't worry, we can hear you beautifully. Go for it.
Fancy with the laser pointer. And anyway, thank you, Susie, and thank you for the invitation to present again at the Alport workshop online. So as Susie said, I'm going to focus on today's talk with how we think treatments work in Alport syndrome. So I'm just going to do a very quick recap of kidney structure and function. Most of us are born with two kidneys, and in each of these kidneys we have these specialized units called nephrons. We have about 1 million nephrons in each kidney, and this is where blood filtration happens. So the filtration occurs in the glomerulus, which is zoomed in here. And the tubular structure is preparing the waste for excretion. But I'm going to focus largely on the glomerulus because that's very important in Alport syndrome. And it's a bundle of capillaries. So these are tiny blood vessels called capillaries, and it's the capillary wall here at the bottom, which is the filtration barrier. So inside this glomerulus, we have some very special cells and matrix scaffolds. And you can see on this movie on the left, the podocyte, which I think is probably the most famous cell and perhaps the most beautiful in the glomerulus. And these cells sit on the outside of the glomerular capillaries. and they attach onto a really important structure you can see in grey here, which is the basement membrane. And together with the pink cells here, the endothelial cells that are lining the inside of these blood vessels, then this structure altogether makes up the filtration barrier. And this is a really special filter because it allows water and small molecules to pass through, but it prevents large proteins and cells from leaving the blood. And we can measure how well this filter is working by measuring something called the GFR, or glomerular filtration rate. And we can also measure how well this filter is working by looking for protein in the urine, because in a healthy filter, we would see very little protein excreted into the urine. So let's think about these matrix scaffolds a little bit more on the next slide. And these movies show really high power electron microscopy images where we're able to scan through these blood vessels, these tiny blood vessels in the kidney filters. And what these studies allow us to see is abnormalities in these structures, such as the ones that I'm highlighting with the pointer here and also with the yellow arrows. So, so these have really, over the several decades, informed us about the structure in these important filters. And so we've got a good idea of what they look like, but what do these structures contain? Well, basement membranes have been studied for decades, and many studies over the last 5 decades have established that they're composed of a really important toolkit of essential proteins, and they include laminins. So we can see in green the laminin network here, and also type 4 collagen. And these are 2 really important protein networks in the glomerular basement membrane. And they help other proteins to connect onto them. And they also attach onto the cell surface by proteins called receptors. So this slide is already quite complicated, but the picture's actually a lot more complex, as with many things when we start to look into them in science. And a few years ago, we published a study where we had used something called proteomics to look at the complexity of these matrix scaffolds in the kidney filters. And what we found was over 140 proteins in these special glomeruli or filters. And in subsequent studies, we've shown that the levels of these proteins change during kidney development and kidney disease. And what these studies help us to do is really build up an understanding of the biology. And that's essential if we're wanting to understand then what happens in the context of disease. So what do we know already about Alport syndrome? Well, as you will have heard from many of the other online workshops, Alport syndrome is caused by a genetic change in one of the genes, the collagen 4 genes. And so this is in COL4A5, which causes X-linked Alport syndrome, COL4A3 or COL4A4, which causes autosomal recessive Alport syndrome. And these genes are really important for making a type 4 collagen, the alpha 345 version of type 4 collagen. So there are 2 other versions, the 112 and the 556 version, but it's the alpha 345 version of type 4 collagen which is important in the glomerular basement membrane. And we can see that schematic here of the network structure there from a nice image from Billy Hudson's lab. So these changes, these gene changes, cause abnormal protein networks in this basement membrane structure in the kidney, but also in the ears, in the cochlea and in the eyes. And whilst most of our research and focus in terms of Alport syndrome biology and treatment has been focused on the kidney, it's equally important for us to think about the hearing loss and the eyes. And in fact, we've had a couple of really excellent workshops in this series focusing on ears and eyes. But overall, the link is with the basement membrane, these really important scaffold structures. So if we go back to the kidney and think about the progression of kidney disease, then over years, these healthy filters become scarred and get to the point where they're not working anymore. They're irreversibly scarred. And this correlates with the clinical picture, which will start with leaking of blood or protein followed by a reduction in the GFR, the function of these filters, as they start to scar. And ultimately that progresses to the point of needing dialysis or a kidney transplant. And if we're thinking about treatments for Alport syndrome, then they need to be starting at this critical point in that progression where we've still got healthy filters and where it may be possible to either delay the progression to scarring or even reverse. This would be an ideal to be able to reverse some of that damage so that we can hold on to those healthy functioning filters. So what does this look like in real life? Well, I've shown you the schematic there on the previous slide, but we can look at this pattern with kidney biopsies. And although we don't do so many biopsies now, with genetic testing being the number one way to make a diagnosis in Alport syndrome, we can see many of the changes on kidney biopsy. And so we can look for this special type 4 collagen network and observe that using light microscopy. We can look for patterns in histology and then using electron microscopy. And some of these patterns are very typical to Alport syndrome. So the changes in the basement membrane that I'm just outlining here are quite typical. The splitting and the basket weave appearance, it's called, is quite typical. But some of the changes that we see are also seen in other genetic causes of glomerular disease. And one of those changes is FSGS, which stands for focal segmental glomerular sclerosis. And we sometimes see that in Alport syndrome, but it's also a pattern that is seen in other causes of glomerular disease. So if we look, in fact, at that wider picture, then genetics and genetic studies over the last 3 decades have really expanded the number of genes that we now consider linked to these filters in the kidney. And so there are over 80 genes that have been identified, and more will come. And what the identification and discovery of these genes really drives our understanding of the biology. And that in turn will help us to understand more about the disease processes and help us to think about ways that we can target those processes with new treatments. And so across these many abnormal genes, there is common pathology, as I've mentioned, but also common pathways that are involved. And as such, the treatments that we're currently using for Alport syndrome is based on this knowledge, and it's shared across a number of different conditions. So if I just focus on our current strategy in terms of how we're trying to delay progression in Alport syndrome, then what we're trying to do is promote some of the features in this top half of the table here, which are protective in terms of kidney function, and we're trying to reduce or eliminate some of those on the bottom half of the diagram. And one of the key strategies we have is to control blood pressure if it's high, and also to reduce proteinuria. So that is a fairly early feature in Alport syndrome, and we know that with ACE inhibitors and angiotensin receptor blockers, we can reduce proteinuria. And if we do that, we can extend the survival of kidneys by 10 or 15 years. But there is still more that we can do, and that's what we're here to learn more about and hear more about this evening, and that is to look at new treatments that could extend that kidney survival even further. So how do we know if our current treatments or new treatments work? How do we measure that? So I'm just on the next couple of slides going to talk about endpoints that we use in clinical trials and how they relate to some of the biology that I've been talking about. So if we're thinking about kidney function, then one outcome is kidney failure. And that's our goal, really. We want to delay or prevent even kidney failure in kidney disease. And so that's a hard clinical endpoint. But it can take many years to reach the stage of kidney failure. And so what we have in addition are what we call surrogate endpoints. And these include proteinuria and GFR, measurement of the glomerular filtration rate, which help us to monitor the effects of current treatments and new treatments. And so for proteinuria, so this is, as I've mentioned, it's measuring protein in the urine. And we perform a test called the protein-creatinine ratio, the PCR. And our aim with treatments is to reduce proteinuria. With the GFR I've mentioned, from a blood test, we measure creatinine, we calculate the GFR, and the goal of treatments is to slow the decline in GFR. And so these are two surrogate endpoints that will hopefully help us know that we are on track to delaying or even preventing kidney failure. And I just wanted to mention one study from patients with nephrotic syndrome where these surrogate endpoints have been studied. And so this is looking at proteinuria. And in nephrotic syndrome, there's proteinuria levels are very high. And so there's a comparison in this study between getting a complete reduction in proteinuria and a partial reduction in proteinuria. And so they're the green and the yellow lines. And the comparison is made to no response to treatment. And so you can see over the almost 3 years of follow-up, then kidney survival is different. So it's less in the ones where there was no response initially, but actually these two markers are fairly close. So these sorts of studies help us to think about the way that we can monitor new treatments in clinical trials and really help us to design better clinical trials. So what is in store in terms of future treatments for Alport syndrome? Well, I have to say, I think it's a really exciting time in terms of drug development syndrome, drug development in Alport syndrome. There are lots of new compounds and strategies in the pipeline, and a few of those are listed here. And the basic message I'd put across here is that a lot of this has come from efforts over decades to try and understand more about the biology and the basic mechanisms that underlie the disease. And Michelle will talk in more detail about some of these specific agents, but I will just finish up by talking about the medium to longer term prospects in this slide. And I hope we will get to the point where basement membrane repair is a possibility, and that may well come in the form of manipulating genes, and so that could be with gene replacement, gene editing technologies, so CRISPR, exon skipping. We've heard about exon skipping in one of the workshops recently. It may even come in the form of protein linkage based repair, and this is where there are already studies in the research setting, in preclinical models in the mouse, where the idea here is that you would reinforce the connections between many of those basement membrane proteins. It may even come in the form of protein replacement therapy, and some of these studies have also been are already underway to investigate that as a prospect. So overall, I hope in the next 10 to 15 years, we may well see some of these strategies coming through. And in terms of the treatments that are currently in clinical trials, then Michelle will elaborate in the next talk. So I'm just going to finish up by my acknowledgement slides. I want to thank all of the fabulous team in my lab, our funders, and also thank you for your attention. Thank you.
Thank you very much, Rachel. Excellent. I love your diagrams. They just kind of bring to life what is going on at such a tiny level in the kidneys, and it's very helpful to see that. This is a bit of a basic question, so forgive me, but you mentioned the word target. Can you just recap what a target is and why targets are important, and what in Alport syndrome are a couple of exciting potential targets?
Yeah, okay, so I guess that's where we're targeting treatment. So it could be a pathway, a particular protein within a pathway, or it could be a process. So I guess with the treatments that we know already, ACE inhibitors and angiotensin receptor blockers target the renin-angiotensin-aldosterone pathway, and so they inhibit that pathway, which early on, from a few decades ago, we've known has been important in terms of kidney disease. So that's a pathway that's been targeted by a drug, and additional targets from all of that understanding of the biology. Michelle will go into some more details in terms of some of the drugs that are coming through in clinical trials and from some of the preclinical studies, but they include the receptors where basement membranes are attaching to cell proteins on the surface of cells. So drugs that are targeting receptors, or they could be drugs that are targeting inflammation for later stages of Alport syndrome. So this is broadly what we're thinking about when we say we use targets.
Okay, great. It just reminds me, the biology is such a complex thing, and the more that we understand, the more you understand in terms of potential targets. But it's a kind of a complex area. It just reminds me how complex the kidney really is. You've shown us how an Alport kidney becomes fibrotic, and the basement membrane is sort of unable to work as a filter. All us renal patients sort of watch our glomerular filtration rates, GFRs, very carefully, assuming the lower the GFR, the more the fibrosis in a kidney. So what is the optimum GFR, i.e. with healthy filters, as you call it, that you talked about, for someone to participate in a clinical trial?
Yeah, so I think if we go back to the schematic where I said actually where we want to intervene is where there's still an opportunity to delay the progression, or even reverse any changes that may have happened, and so I guess that's it's hard to give a kind of GFR cutoff for that, but in the I guess in terms of the biology, we still want to have functioning filters, and the prospect of being able to undo some of that damage in terms of fibrosis and scarring, I think, is a more remote possibility, and it's not clear that any of our current treatments or proposed treatments will be able to do that. So we're still going to need to have some functioning filters, and the earlier you can potentially start that treatment, which is what we're doing with ACE inhibitors, the earlier you will intervene and protect still functioning filters.
Yeah, and maintain those healthy filters. That's good to hear. We have a couple of questions here from Joy Toll. Just trying to find, whoops.
Susie, perhaps I just take over. So Joy Toll asked us, how does dental health affect Alport progression. I think what that means is dental health in terms of recurrent bacteria infection and so on. Rachel, I already answered it, but go ahead and answer.
Yeah. I mean, I think so in terms of we know there's a definite link between infections and kidney health. And so we're in Alport syndrome, what we're wanting to do is preserve kidney function for as long as possible. And so if we can reduce any injuries or if we could insults to the kidney, then that will help us to preserve the function for longer. And so in terms of infections, particularly if they're affecting the kidney, we know that they can cause an episode of injury, and we may well see a decline in the baseline function as a result of that. So any strategies that reduce infections, whether that is through dental hygiene or otherwise, will also help with the overall goal of trying to preserve kidney function.
Okay, I have another tough question for you because of your running history. So we are asked, well, limited sports have a negative effect. So what kind of sports should you do? Would you prefer heavy weightlifting? Would you recommend marathons, or what would you do?
So I think my overall response to that is that exercise is a very positive thing for so many reasons, not only our kidney health, but our general overall well-being. And so that's, I guess, you want to promote that and allow that wherever possible. And then I guess it's for individuals to choose amongst the types of exercise they would want to do, but to be mindful of any, I guess, high-level exercise in terms of what its effects may be, and the way to maybe on kidney health. And the way to assess that would be to do that carefully with monitoring, if that was a particular passion. But I think I don't know, Oliver, what would you, is there anything in particular that you would avoid?
I already answered it. So I really recommend not to do heavy weight lifting. Like adolescents like to drink all these protein shakes and want to look like Arnold Schwarzenegger, which does not make sense because it really negatively affects your blood pressure and will lead to earlier renal failure. So I really would recommend to do any sports, but don't overdo it. Yeah. So we also have the question if current renal treatments affect hearing loss. Do we have any information about that?
About current treatments, yes. So I think I mentioned that our understanding of the biology in terms of hearing and eye problems with Alport syndrome is definitely lagging, and we definitely need to improve that area of understanding. But our current treatments, we don't have strong evidence that they are impacting on the hearing loss. And I think one of the aspects that we'd love to see in clinical trials coming forward is a parallel arm or assessment of whether the new treatments are also going to have a benefit in terms of prolonging hearing and other the other features in Alport syndrome. And to a certain extent, we should also look for signs of a positive effect for hearing in some of the preclinical models where possible, but it's not always possible. So for sure, we should be adding that into our monitoring in clinical trials.
Okay. I have another question about, well, it might be easier if you answer it. We have the question if currently my creatinine levels are higher after I do sports. And just to answer that, it's quite easy because creatinine is a muscle enzyme. So having increased creatinine levels after doing sports does not mean that your kidney function fails. It means that you used your muscles. So I would not worry about that. Yes, let me read this. Yes, so in summary, do sports, but don't overdo it. And make sure that you are not running faster than your doctor, in my term at least. We have a question from Neil Turner, and that might be the final one. Well, for you, Rachel, Alport starts with hematuria, but proteinuria develops later. What do you think is behind that, Rachel?
Yeah, no, it's something that I've thought a lot about, and it's so I wonder whether this is to do with when you so that early leaky barrier where we see the hematuria at the very early stage, that when we certainly when we look in the kidney in the Alport mouse, then the basement membranes there are very thin. So a thin basement membrane is definitely associated with being able to lose red cells, and so hematuria. And then proteinuria develops at a later stage of the during the progression. And is that then coinciding with when we are seeing changes in the cells as well as the basement membrane, or even just more changes in the basement membrane where it's starting to become more irregular and split? So I don't have a good answer for you, Neil, but quite possibly it's to do with the amount of podocyte effacement and the ability, therefore, for the filter to hold on to protein.
Okay. So thank you very much. And I think we are ready to go for the next talk.
Excellent. Great. Thank you, Oliver. Time to get Michelle presenting. Michelle, can you share your screen, please? Great. Michelle, we can see the slides. I'm not sure I can hear you yet.
Can you hear me now?
Yep, I can hear you beautifully. Thank you. Over to you.
All right. So thank you to Susie and to Alport UK for inviting me today. This is always nice to speak to both patients and clinicians and researchers. So it's a great group that you pulled together. So I'll be talking about current and future therapies, and Rachel really set me up nicely to be able to go through all of this. Just some disclosures, I'm the site PI for clinical trials, and we will be talking about some of these today. And I'm also on the medical advisory board for the Alport Syndrome Foundation. And I think this experience of working with the Alport Syndrome Foundation has really cemented for me the importance of moving these treatments along. They're not just theoretical treatments for a rare disease. This really impacts patients. So it's important to move these all along. We're going to talk a little bit about current treatments, so ACE inhibitors, ARBs, and I'm going to spend a little bit of time on this because I'm always amazed with patients who enroll in our Alport Syndrome Registry or who are screened for clinical trials who are not currently receiving ACE inhibitors or ARBs. It's about 25% to a third of patients are not getting these drugs, and we know that they're beneficial. And then we'll be talking a little bit about future treatments. And as Dr. Lennon mentioned, I think the holy grail of treatments is to really fix that basement membrane. So replace those proteins that are missing and reform that basement membrane so it works correctly. But we're not quite there yet. So I'm going to be talking about what can we do in the meantime to slow down the progression of chronic kidney disease. And just to remind everybody, there are no FDA or EMA or other regulatory body approved treatments for Alport syndrome. So everything that we'll be talking about today is off-label and not approved for Alport syndrome. So we've heard a little bit about ACE inhibitors and angiotensin receptor blockers, and just wanted to remind everybody what these do. So ACE inhibitors and ARBs, they dilate the afferent arteriole. So Dr. Lennon showed us that we have 1 million of these filters in every kidney. There are tiny capillaries within that where the blood flows through. And there's a blood that goes in and blood that goes out. And what ACE and ARBs do is they dilate this efferent arteriole, and they reduce this pressure that's within the glomerulus to decrease the pressure on that abnormal basement membrane. And we think that that is beneficial in Alport syndrome. They also have antifibrotic and antiproteinuric pathways, or affect they're also antifibrotic and antiproteinuric, so they have a number of beneficial effects. Now, in Alport syndrome, it's a nice disease to study as a researcher, because there are so many animal models available. So there are X-linked Alport models. There are autosomal recessive Alport models, there's dog models. So we have a number of ways that we can test potential therapies, and these have been used throughout the years. The first study was done by Dr. Gross, our esteemed moderator, and published in 2003, where he treated Alport mice with ramipril, an ACE inhibitor, and found that this could double their lifespan, and lifespan in Alport mice really is dependent on their kidney function. So just by treating these Alport mice with ACE inhibitors, we're able to double their lifespan. So then he looked at patients with Alport syndrome through the European Alport Registry, and looked at 283 patients with Alport syndrome over a mean follow-up of 20 years, and then stratified them by whether they had received treatment with ACE inhibitors. So on the y-axis here is the percent of patients on renal replacement therapy, so dialysis or transplant, and then the x-axis time. So in the red line here are patients who never received treatment with ACE or ARBs, and they had an average time to end-stage kidney disease of right around 23 years, so relatively early. Patients who started taking ACE inhibitors once they already had chronic kidney disease had a delay of a couple of years. So even starting later on, once that fibrosis had already started to happen, was able to delay end-stage kidney, or was associated with a delay in end-stage kidney disease. And then the really interesting line here, I think, is this green line. So these are patients who started treatment with ACE inhibitors once they already had proteinuria. So once they had protein in their urine, even if their kidney function was normal, were treated with ACE inhibitors. And they had a very significant delay in their end-stage kidney disease of up to 40 years compared to 23. So about an 18-year difference in time to end-stage kidney disease in patients who were treated with ACE inhibitors at the proteinuria stage. Now, the blue line here are patients who were started on treatment when they just had microscopic hematuria or very low levels of protein in their urine, what I still like to call microalbuminuria, although I know that's falling out of favor. And none of the patients in that group achieved end-stage kidney disease, but you can see that there were relatively small numbers in that group into later ages. So over the past year, in fact, just this summer, there was a publication from Japan that really confirmed this data. So when in science, you always like to see things in a couple different ways to confirm this. And in Dr. Nozu's group out of Japan, they looked at 430 patients, all were X-linked males, and looked at their kidney survival over time. And what they found is that patients who were not treated with ACE inhibitors are this dark line, and they reached end-stage kidney disease around age 25 on average. And patients who were treated with ACE inhibitors had a delay to about age 40. So very consistent with the European data. This is almost the same. So very important to note that this change, that ACE inhibitors are associated with slower kidney function. Now, of course, these are retrospective studies. They're not prospective. They're not randomized control trials, our gold standard. But randomized control trials in Alport syndrome are very challenging because it takes so long for kidney function to decline. So you may need to follow patients for 10, 20 years to really see a difference. And that's why we will be sometimes looking at surrogate outcomes that Dr. Lennon mentioned, changes in your GFR, changes in protein expression over time. Now, in the Japanese registry, they identified risk factors for end-stage kidney disease. So who was at highest risk of early end-stage kidney disease. And they found that hearing loss was associated with increased risk of end-stage kidney disease. If alpha-5 type 4 collagen was absent in your kidney biopsy, so we know in some patients with Alport syndrome, alpha-5 is there, it just is abnormal. And then patients who have truncating mutations. So truncating mutations are mutations where the protein is cut off early. It can't form the entire protein. And these mutations generally mean that alpha-5 is absent, and that entire type 4 collagen network in the basement membrane is absent as well. So one thing that has always been a question in Alport syndrome is whether if you have these very severe mutations, can you still benefit from treatment with ACE inhibitors? And Dr. Nozu's group looked at that question as well. So they took all of their patients and they divided them up into truncating or non-truncating mutations. So the non-truncating mutations, these are the missense mutations, the relatively mild Alport mutations. And the red line are patients with non-truncating mutations who were not treated with ACE or ARBs, and they reached end-stage kidney disease at around the age of 33. And patients in the blue line are patients who were treated with ACE or ARBs. So in patients with relatively mild mutations, there was a 17+ year difference in time to end-stage kidney disease. So those were the mild mutations. And what about these severe truncating mutations? So the black line are patients who did not receive treatment with ACE inhibitors. Their time to end-stage kidney disease was right around age 16. And patients who were treated had a time of median time of end-stage kidney disease of around 28 years. So as a pediatric nephrologist and as a mother, I cannot express how important it is to delay that time period between age 16 and age 28. There's so much happening developmentally. They're finishing high school, they're going to college, they're developing what their career is going to be. And if you have to interrupt that with a kidney transplant in that period of time, it can be really devastating. So even though it's a smaller difference in end-stage time to end-stage kidney disease in patients with the more severe mutations, there's definitely still a benefit to treatment of those patients. So just because patients have very severe mutations doesn't mean they won't necessarily respond to treatment with ACE or ARBs. So based on these studies, we wrote clinical practice recommendations that recommend in any patient with Alport syndrome who has protein in their urine, they should be treated with an ACE or an ARB. Patients who just have microalbuminuria, or these small levels of albumin in their urine, should really consider treatment if they have a family history of very early end-stage kidney disease, or if they have one of these severe truncating mutations. And for patients in the hematuria category, we really didn't have information at that point to be able to make recommendations one way or the other. So Dr. Gross again decided to answer this question through a clinical trial. We wanted to know how early should we be starting ACE or ARBs in patients with Alport syndrome. So he took 66 children with Alport syndrome in Germany who had very early stage disease, all had normal GFRs and all had normal blood pressure. So very normal group of children. Average age was about 8, and randomized them to ramipril or placebo. And it turns out that this is a very difficult thing to ask parents to do, to randomize their children to receive a placebo. And it was challenging to enroll the study and wasn't able to get the numbers that he wanted to, but was able to continue to follow the patients who didn't want to be randomized, who were treated with ramipril, to be able to get very important natural history data and safety data on those patients. Followed those patients for up to 6 years, and looking at the primary outcome was progression of albuminuria. So typically a doubling or tripling of albuminuria, depending on where you start, were the outcomes of interest. And what he found is that in patients who were treated with ramipril, they had about a 50% reduction in the incidence of disease progression compared to placebo treated patients. Now, of course, the way that statistics work, because of the small numbers, this was not a statistically significant difference, but there was a trend toward improvement in patients with ramipril, both in the proteinuria progression and in the GFR numbers. Now, Dr. Gross did something that was very interesting to help improve some of the statistical power of the study. He took the open label arm, so these were the patients who were treated with ramipril, and did comparisons with a similar group of patients from the US who were followed in a natural history study. So we had natural history study from patients in the US who were untreated, and followed those along, and was able to compare that to the open arm group, and also showed an improvement in patients who were treated with ramipril. And I think one of the most important parts of this study was really the safety data that came out of it. So we were able to show that patients or Dr. Gross was able to show that patients who were treated with ramipril it was safe and well tolerated in that group. So the clinical practice guidelines are in the process of being updated. And I think the important thing is to have a discussion with families and with patients who are at this very early stage of chronic kidney disease or of Alport syndrome, to talk about, is this something that they want to treat, that they want their child to be treated with. So now we're just going to move on to some of the clinical trials that are ongoing. And there's a variety of people on the Zoom today, so just wanted to make sure we're on the same page with regards to how do we get drugs to the clinic. So we start with preclinical studies, so the cell culture and the animal model work that Dr. Lennon is working so hard on in her lab. And once you identify treatments that work in the lab, then you can move into phase 1 studies, which are generally healthy adult volunteers who get a drug to look at safety, dosing, side effects, and usually these are pretty short-term studies. Phase 2 studies are the first phase where the drugs are actually used in the group that they're targeted for. So this is the first time where patients with Alport syndrome might receive the drug. And this is primarily for safety evaluation and sometimes to look for any early signals for efficacy. Phase 3 studies are the big studies. These are the studies that compare the drug to either a placebo or a comparator to see whether it's effective, and also get more information about side effects. And then if that study is positive, this generally leads to approval. Sometimes more than one phase 3 study is required to get approval, but that's the general path. And then there may be phase 4 studies, which are more long-term studies that happen after approval. So once patients are able to get the drug, sometimes the regulatory bodies will require that these longer-term studies be done. And we're just going to go through these kind of quickly. The first drug is an anti-microRNA 21 agent, and the name of it is SAR 339-375, which is not very catchy, so they're going to call it ladamirsen. This anti-microRNAs are 21 or 22 nucleotide, highly conserved RNAs that work as a post-transcriptional regulator of gene expression. So these microRNAs attach onto RNAs in the cell and lead to degradation. So they're another way that the cell regulates translation within the cytoplasm. And these always blow me away because they were first identified in 2001. So after I graduated from medical school, an entire new way of regulation of protein expression in the cell was identified. And I can't imagine what else we're missing and will come down the pipeline in the future. So microRNA 21 was found to be upregulated in mouse kidneys, and it leads to fibrosis. So anti-microRNA 21 agents are anti-fibrotic. They're able to suppress this fibrosis pathway. And if you treat Alport mice with this agent, it slows the progression of their chronic kidney disease. So it seems like a very promising avenue of attack. And this is currently in phase 2 trials in humans with Alport syndrome. So this is a study that's sponsored by Sanofi, and the primary outcomes that are being looked at are the change in GFR from baseline to 48 weeks, so a relatively short period of time, and also importantly looking at adverse events. And this study is enrolling currently around the world, so there may be a site near you. We're a site here at the University of Minnesota, as well as sites in Australia, China, France, and the UK. They are going to include 45 subjects between the ages of 18 and 55, male or female, GFR between 35 and 90. And they're going to do something that's very smart, which is to enhance the enrollment of the study to patients who are at higher risk of progression. So there, you either have to have a decline in GFR of 4 per year over 2 to 3 years prior to the study. So these are patients who are getting worse. You have to have high amounts of protein in your urine, which we know is another risk of getting worse. Or you have to be a male with X-linked Alport syndrome between the ages of 18 and 23 and a GFR already below 90. This is another group that we know is going to get worse over time. Patients are enrolled. They receive either the drug or placebo by injection weekly for 48 weeks. And then at week 48, everybody gets the drug for another 48 weeks. So to allow for more information. So that is the first study that is ongoing. The next drug that's being evaluated in Alport syndrome is bardoxolone. So bardoxolone is a agent that activates NRF2 and upregulates the antioxidant response while it suppresses NF-kappa B and diminishes pro-inflammatory signaling. So it's basically an anti-inflammatory and also works in the fibrosis pathway. And this drug was initially evaluated in patients with diabetic kidney disease. Unfortunately, the studies in diabetic kidney disease were stopped early due to an increased risk of cardiovascular death in the patients who were treated with bardoxolone. It's being trialed in Alport syndrome because this is a group of patients that is generally younger and healthier than diabetic patients. So the theory is that this will be better tolerated in patients with Alport syndrome. There's no published data in Alport mice, and in humans, it's currently in phase 2 and phase 3 studies. And this is the Cardinal study sponsored by Rheault, also an international study and started in March 2017. And enrollment is currently complete, so they're not enrolling new studies, but this was an important study to show that clinical trials in patients with Alport syndrome can be completed. You can enroll patients with Alport syndrome into clinical trials. So I think from a clinical trial standpoint, this was an important step. Their phase 2 results were reported at ASN in 2017. They looked at just 12-week outcomes looking at GFR, and over 12 weeks of treatment with bardoxolone, GFR increased by an average of 13. So an increase in GFR in those patients. The phase 3 study is going to be a double-blind randomized study, and the primary endpoint is change of GFR relative to placebo at week 48. So again, a relatively short period of time, and looking at change in the baseline after a washout as well. So there are some suggestions that this drug may have some hemodynamic changes that affect GFR. So that is going to look at whether that's a conserved benefit. Now, Dr. Lennon published a commentary a couple years ago, and I think that it's important to think about whether is an increase in GFR a good thing for patients with Alport syndrome. We talked before that treatment with the ACE inhibitors and the ARBs really work hard to reduce the GFR. So for example, if the black line is a patient with Alport syndrome who's untreated, their kidney function slowly gets worse over time. If we treat them with ACE or ARBs, initially this reduces the GFR, but we think that by doing that, it helps to slow the progression on this green line to prolong kidney life overall. We don't know if increasing the GFR is a good temporary or a good initial finding, but then does this hypothetically increase the risk of progression or increase the risk of progression over time? And we know that just this 1 year of follow-up in the Cardinal study may not be long enough to answer that question. So we really need longer-term follow-up for a lot of the studies that will be done in the future. Another very interesting drug that's currently in development is sparsentan. And sparsentan is a dual endothelin antagonist and angiotensin 1 receptor antagonist. Endothelin is activated in Alport kidneys by hypertensive stress. So stress on the endothelial cells leads to release of endothelin. And then they activate mesangial cells that kind of insert filopodia into the basement membranes and deposit ectopic laminins and ectopic collagens. these abnormal matrix proteins then signal to the podocytes that are sitting on top of it and lead to these fibrotic pathways as well. So these drugs work in this drug works in two different ways. It reduces intraglomerular pressure, and it also blocks this endothelin signaling. In animal models, it slows progression of kidney disease in Alport mice. And this is a very interesting drug because it may also affect hearing. So endothelin may be involved in the hearing loss pathways in Alport mice. And there are some studies that are being published in abstract form. We're waiting for them to come out in manuscript form, showing that may actually be a benefit in hearing loss as well. So this is really the first drug that might be looking at both of these items. This is a phase, there's no human trials in Alport syndrome currently, but this is in phase 2 and phase 3 studies in FSGS, which is another glomerular disease, and in other glomerular diseases as well. So this will be one to have our eye on in the future. DDR1 is a receptor between the podocyte and the basement membrane. It's a matrix receptor. And there's a drug that was evaluated in Alport mice called 2.45. It needs a catchier name, so somebody can come up with that for them. And this drug blocks the aberrant signaling between the basement membrane and the podocyte. If you treat Alport mice with this drug, it slows the progression of their chronic kidney disease. There's no current human trial. So this is another drug that's in development, but very early on in the process. And finally, the new kid on the block that we are going to be hearing a lot more about are the SGLT2 inhibitors. So these are drugs that were initially designed for treatment of diabetes. They block type 2 diabetes. They block one of the glucose transporters in the kidney to allow people to pee out more glucose. And by doing this, it decreases the intravascular volume, and through tubuloglomerular feedback, reduces the pressure through this afferent arteriole and decreases pressure within the glomerulus. There's no published data in Alport mice that I'm aware of, but there are human studies in phase 2 and phase 3, not particular to Alport syndrome, but chronic kidney disease in general. And in fact, last week there was a study published in the New England Journal of Medicine using dapagliflozin, showing a very significant benefit to patients who were treated with dapagliflozin compared to placebo-treated patients in their kidney disease outcome and cardiovascular disease outcome. So this is really going to be the future of treatment of all patients with chronic kidney disease. And if we combine RAS inhibition and SGLT2 inhibition in Alport syndrome, we may really be able to reduce that pressure within that glomerulus. So you get the afferent vasoconstriction due to SGLT2 inhibition, you get the efferent arterial dilation due to RAS inhibition, and you lower this intraglomerular pressure, take the pressure off that abnormal basement membrane. So in summary, ACEs and ARBs are recommended for treatment of all patients with Alport syndrome and proteinuria, and we really need to think and talk through it thoroughly, our early stage patients with Alport syndrome, whether they should be treated as well. Current clinical trials in Alport syndrome are testing bardoxolone and anti-microRNA 21, both in that fibrosis pathways that Dr. Lennon was talking about. And there are a number of potential agents in the future that may be, where we may be able to also find new targets for treatment of Alport syndrome. So that is all I have.
Excellent. Michelle, thank you very, very much. It's fantastic to have a summary of those treatments and being able to compare and contrast. I have a question to you very specifically, because I represent quite a large community as a patient with X-linked Alport syndrome and currently good renal function, etc. What is your advice around ACE and ARBs, the new flozins, and contributing to clinical trials for other potential drugs as a woman with X-linked Alport syndrome?
Mm-hmm. Yeah, that's a good question. And in the Alport research community, that's a big area of discussion. Should women with Alport syndrome be included in the clinical trials? Because there is so much variability in outcome. So as we know, some women with X-linked Alport syndrome just have microscopic hematuria their whole life and never really have any proteinuria or any kidney problems, whereas other women do have progression to end-stage kidney disease, and some even very early on in their 20s. So being able to identify women who are at highest risk of progression is important, and I really strongly believe that they should be included in clinical trials. So those may be women whose GFR is already low, so patients who or women who have already started to lose GFR, and women who have high degrees of protein in their urine. Those are probably two things that we can look at to really identify which women are at highest risk to progress.
Okay, that's great. Thank you. That's really helpful. Also, too, as a children's kidney doctor, what would your advice be? Now we have the opportunity to for patients to contribute to these trials. What would your advice be to a family who have a child with Alport syndrome to actually participate in a trial?
Mm-hmm. Yeah, I think participating in clinical trials is really important. It's really the only way we learn more about the disease. So I think for children in particular, the things to weigh as far as participating is safety. That's really number one. Do we have enough safety data on this drug, whatever it may be, to know that this is going to be safe for them? So that's the first thing. And of course, we're not going to know all the answers when we start, but we know we're monitoring closely. And then the second is the drug targeting a pathway that happens early? So I don't want to give a 5-year-old a drug that's targeting these fibrosis pathways, because that may not be quite active yet. We may need to be targeting more the pathways that are involved in the stretch of the basement membrane or the mechanical strain on that abnormal basement membrane to target that.
It's really helpful to understand the specifics around it. It's invaluable, actually, as a parent. Thank you. Oliver, shall I hand over to you for some questions?
Yes, of course. So we have several questions that are hard to answer, so I leave it open to Michelle to answer them. First of all, Matt Hall asked you, should SGLT2 inhibitors become standard of care for patients with proteinuric stage of Alport syndrome, extrapolating the data from the other CKD studies?
In a perfect world, we would have a randomized control trial of Alport syndrome patients treated with SGLT2 or not. That is really going to give us the answer. But given the really significant benefits shown in the general CKD studies, I don't know that that's going to be feasible anymore to randomize somebody to a placebo, to randomize a patient with Alport syndrome to placebo. So we may have missed our window to do that study.
Totally agree. And you know that we have a quite frustrating 12 or 18 months of trying to set up an international SGLT2 inhibitor trial. I applied for funding in Germany, and within the next 12 months, we will know if we are able to run a small clinical trial. So I think it's worthwhile. It's better to confirm it with Alport patients, but still the other CKD data are very convincing. So we have another tough question for you. Let me start with Richard Naylor's question about the SGLT2 emitters that cause sugar to be present in the urine. And Jeff Miner's work showed that protein passing through the kidney is damaging. So could it be possibly the way that sugar passing through the distal tubules is also damaging to the kidneys?
And I would say we don't have any evidence for that. I mean, certainly sugar is not supposed to be in the urine, but in patients who are treated with these SGLT2 inhibitors, we don't seem to have any increase in chronic kidney disease. In fact, it's beneficial. Now, we do see some increase in urinary tract infections in patients because that sugar is there. It's great for bacteria to feed on, but really no other adverse effects there. And then I see Dr. Naylor also had another question: what proteins are having their expression affected by miR-21? And that's a really tough question. I'm just gonna, you're not gonna be able to read this, but this is a list of all the proteins that are targets of microRNA 21. So we really don't know which specific target is affected, and more preclinical and basic science work needs to be done to figure out which exact one is important there.
So another very, very important question is, should X-linked Alport patients, I would not call them carriers, heterozygous mothers, obviously, should they be started on ACE inhibition or ARBs?
Yep, and that's a great question, and I completely agree with you. And that's one of my pet peeves is that these women are called carriers because they are not carriers. They actually have expression of disease. They're at risk for end-stage kidney disease, so we should think of them as such. And if a woman with X-linked Alport syndrome has protein in their urine, absolutely, they should be treated with ACE inhibitors. Now, of course, ACE inhibitors have complications in women of childbearing age in that they can cause birth defects. So they can't be used in women who are anticipating pregnancy or who are pregnant. So they sometimes have to be stopped for that period of time.
So do you think we just have a very, very few mothers that are heterozygous X-linked, or is it a common disease we're just not aware of?
It's definitely more common than we think it is. Yes. Once you start looking for it, you will find it.
Yes, and I'm afraid that, well, I'm an adult nephrologist, so most adult nephrologists are not really aware of the fact that, well, you can have Alport syndrome being in your 50s or 60s years of age, and still you have Alport syndrome and need to be treated. Mm-hmm. Yeah.
Michelle, Oliver, can I interrupt just very quickly on the X-linked? Can you also clarify, Michelle, whether, so you said patients with proteinuria should have ACE and ARBs. We often get asked the question, should patients just with hematuria and no proteinuria start on ACE or ARBs? What's your view on that?
For women with X-linked Alport syndrome without proteinuria, I would not necessarily recommend ACE or ARBs. For patients with X-linked Alport syndrome, or males with X-linked Alport syndrome or autosomal recessive Alport syndrome, I think this is where the results of Oliver's early PROTECT trial come in. So there is likely a benefit. The treatment seems safe. So if a family is willing to start treatment early, I recommend starting treatment early.
Great, thank you. Oliver, have you got more to ask?
Yes, we have one final question from Neil Turner, who tries to make it.
Ask all the hard questions.
So how many of these treatments do you think might be particular for Alports versus for any kind of chronic kidney disease?
Yeah, I think that's a really good question. And a lot of the treatments and the drugs that are in development are more general treatments for chronic kidney disease. They're targeting these fibrosis pathways that are present in many progressive kidney diseases. And Alport syndrome, because there are so many nice animal models, and because patients have a very steady progression of their kidney disease, it's a good disease to test these drugs in. So a lot of the drugs may not be specific to Alport syndrome. It's really when we get to those earlier mechanisms that Dr. Lennon was talking about with the abnormal basement membrane, that's where that may be more specific to Alport syndrome.
Okay. So I have a question about these missense mutations, because this is very, very complicated for me. And you said that, well, the Japanese group showed that patients with missense mutations seem to respond to therapy better. And I'm aware that patients in the US generally do better than in Europe or in Japan. Why is the US better in this term compared to Europe or the Japan people?
Yeah, I think it may have something to do with just the mutation background in the different areas, maybe more missense mutations in the US compared to Europe.
Yes, thank you for this answer. I think it was a selection bias because, well, once the Europeans moved to the US, only those with the less severe mutations were able to get to the US.
Mhm.
Yeah. Actually, that makes it harder to conduct clinical trials in the US compared to Europe or Japan.
Mhm.
Yeah. So we have a question from Andre Weinstock, Alport Syndrome Foundation. What are your thoughts about FSGS patients, focal segmental glomerulosclerosis patients in clinical trials who actually have Alport syndrome? Can we capture data post-clinical or not?
Yep, that's a really important question. So as Rachel showed, some patients with Alport syndrome have this pattern of pathology in their kidney that's called FSGS, or focal sclerosis. And that is also a pattern that's seen in other causes of kidney disease. Some are genetic causes and some are non-genetic causes that we don't really understand very well. So there are a number of clinical trials in FSGS currently that because the enrollment criteria are having this FSGS picture in their biopsy may include some patients with Alport syndrome. So can we then go back and look at those patients to know whether they are responding to the drug or not in a patient with Alport syndrome? And the challenging part of this is that genetic testing is generally not part of these clinical trials. So we may not know which of those patients have Alport syndrome or don't have Alport syndrome in those studies. So it may not be possible to go back and identify who actually has Alport syndrome and who doesn't.
Yeah. And it's frustrating about the FSGS story that it's very political to learn that FSGS can be caused by Alport mutations. So I think it's still a long way to teach other that Alport, of course, causes FSGS.
Mm-hmm.
So we have one question that is, well, it's tough. If you have your choice for a heterozygous X-linked female mother, and you could participate in the microRNA 21 study or an SGLT2 inhibitor study, which of those two studies would you recommend?
Yep, and I'm going to say I can't give an answer to that because the answer is going to be different for every patient. And some of the factors that are going to come into that may be, is there a center nearby you that's enrolling? You don't want to have to travel for 12 hours to get to a study center. Other things to take into consideration is your comfort with risk. So knowing the side effect profile of these medications, if that's very important to you. The SGLT2 inhibitors have been used in thousands and thousands of patients. We have a very good understanding of their side effect profile. The anti-microRNA 21 agents are relatively new. They haven't been treated, haven't been used in as many patients. So the side effect profile is a little bit more unknown. There may be a little bit more specific Alport effect to patient or to treatment with the anti-microRNA 21. But it's really not clear. So those are the types of things to think about when you're looking at entering a clinical trial.
It's a very diplomatic answer. So, yes. And I'm aware that the inclusion criteria for the microRNA 21 trial are quite hard to meet. So I would say that much more would be able to get into an SGLT2 inhibitor trial. But just to make sure that everybody understands, we need to, well, only because we think SGLT2 inhibitors work in Alports does not mean that it really works. And so we still have to work hard to prove it scientifically.
Oliver, Michelle, I have a question for you because I know there's much discussion in the scientific community about the combination of ACE inhibitors and SGL2 on top of that, and then how that affects other trials, etc. Because potentially there's huge benefit for Alport patients. And I'm just interested as to how that might impact clinical trials going forward.
Yeah, that's a really good question, because, for example, patients who are currently screening for the microRNA 21 trial, who've had a decline in their GFR of 4 per year for the past 2 years, and to meet inclusion criteria, if they are now started on SGLT2 inhibitors and have a more of a leveling off, it's going to make it harder to show a difference in the groups at the end of that study. And these are relatively new, where they're not there's no restrictions on SGLT2 inhibitors written into a lot of the trials at this point.
Yes, and just to tell you, well, if we go back 5 or 10 years, we did not have any trial at all. So I think it's still great to have different options to choose from. It really tells you that we will improve standard of care.
As our Alport workshop tradition dictates, we also want you all to check out and contribute one word to a word cloud. So Archie, can you please put into chat now a link? Archie's just put into chat. Please contribute. If you go to that link, it will take you to and put in one word to capture how you feel as we finish this Alport online workshop today. Just wait for those words to come in. How are you feeling after watching the presentations today? Hopeful seems to have the greatest emphasis, which is excellent. Encouraged, excited, informed. Oh, somebody's supper's burnt. That doesn't sound so good. Okay. Rachel, Michelle, Oliver, you've clearly inspired everyone today, as we knew you would. Thank you very much. Thanks to everyone for coming today. We continue our regular schedule of workshops into the winter. Please do let us know if you have any topics or research you would like us to feature. So, for example, if there's a topic that you've heard about today that you'd like us to find out more about and to feature particularly, drop us a line. But thanks particularly to Rachel and Michelle for so helpfully summarizing what is really encouraging treatments and clinical trials landscape. I'd just like to take a moment to reflect back to 2014. To 2014, the International Workshop on Alport Syndrome that we held at Oxford University, that's 6 years ago. And I remember vividly Sharon Largus, myself and Daniel Rheault, Sharon representing the States and Daniel representing wider Europe. We were talking to the scientists, and there were no treatments for Alport syndrome, no commercial companies involved. Today, 6 years on, just 6 years on, there are active trials that patients can participate in, and there are an increasing number of commercial companies involved. And this is amazing progress in 6 years. And as patients, we truly thank all of you working on the biology, as Rachel explained, to better understand what goes wrong and help us understand potential targets for Alport syndrome. And to those of you developing ideas to develop treatments. Thanks to Oliver for asking lots of important questions. And Oliver is somebody who continues to ask lots of important questions around the science. It's such a vital role. And Oliver was one of the key people who actually encouraged us to get everybody together back in 2014. We really appreciate your efforts, Oliver, as a collaborator in our international Alport community. Finally, a massive thank you to Kidney Research UK for your sponsorship, helping fund our Zoom subscription and keeping the lights on for these Alport online workshops. It's so exciting to welcome 2 new participants from all around the world. We've had a huge and increasing interest from places like South America. It's so positive for us patients to see people engaging from a broader range of countries and potentially supporting a more diverse group of patients. Thank you to you all for joining today and for all that you do to help diagnose and support Alport patients. So before you go, some important information on our next workshop. Please note, there is a change to our schedule. The next workshop is changing just one day from Wednesday the 14th of October to a Thursday the 15th of October. The webinar will be at the usual time of 17:30 BST. Note the time change hasn't changed then. But it's going to be on a really exciting topic that has come out of our international workshops, the need to understand modifier genes. So we know a lot about some of the basic genes in Alport syndrome, but not so much about modifier genes. But we've got a huge opportunity. Ron Korstanji is going to talk about modifier genes impacting Alport syndrome. We also have the great opportunity. Ron is also doing some really important work with black bears. Now, how do they relate? So black bears may hold the secret to a cure for kidney disease, says Ron. Well, we'll have to see. If you have any more feedback about this session or want to be added to our mailing list, please email research@alport.info. And Archie will put that in the chat now. Please also follow us on social media to hear updates about our workshops as they happen and details about upcoming research. And well, we hope one day there will be in-person workshops, but certainly I think the likelihood of our next international longer 2 or 3 day workshop might well be very much online. We can certainly achieve a lot online, as these Alport online workshops have proven. Patients can join the Alport Warriors Facebook group, and anyone can hit us up on our Twitter page. That's @Alport UK. For those of you that would like a recording of this talk, we'll be popping it onto YouTube and Facebook pages later this week. Otherwise, a big thank you to you all and have a great rest of the day or evening, wherever you're dialing in from. Thank you and goodbye.